It's my great honor to introduce our next speaker for the state-of-the-art lecture, Agility and Surgical Quality Improvement, to be given by Dr. Joe Sharma of Emory University. Dr. Sharma specializes in thyroid and parathyroid surgery, adrenal gland surgery, and pancreatic endocrine tumors. He routinely performs outpatient parathyroidectomies, outpatient thyroidectomies, and adrenalectomies using minimally invasive methods, and has published various journal articles on these techniques since joining the department in 2006. Dr. Sharma has been a significant driver of standardizing and advancing care, quality, and safety in the programs and services of the Department of Surgery. In 2009, he became the primary steward for the participation of Emory University Hospital in the American College of Surgeons National Surgical Quality Improvement Project, NSQIP. In 2010, he was appointed Chief Quality Officer for the Division of General and GI Surgery. He began serving as the Chief Quality Officer for the entire Department of Surgery in 2016 and was named Vice Chair of Quality, Patient Safety, and Care Innovation for the department in 2019. Dr. Sharma's quality and safety-based achievements include his installment and oversight of the sustained internal auditing and localized to systemic renovation that contributed greatly to lowering Emory University Hospital's readmissions, incidence of surgical site infections, and overall mortality, eventually leading to the hospital being included in the ACS NSQIP 2018 and 2019 listings of the top 10% of meritorious member hospitals. In addition to his Emory work, Dr. Sharma chairs the Georgia Surgical Quality Collaborative, a partnership of 9 hospitals from across the state, and is directing and evaluating the member facilities' information sharing systems and subsequent examination and comparison of clinical outcomes data for the benefit of patients and to reduce overall healthcare costs. Dr. Sharma is a frequent faculty participant in the Emory Haiti Alliance's summer surgical trips to the Central Plateau region, the poorest and most medically underserved area in all of Haiti. I can also tell you that he has been a longtime member of the Southeastern Surgical Congress. He just shared with me that he presented his first surgical paper here many years ago, and he had as a resident, right? As a resident, his first paper as a resident was presented at one of the meetings here many years ago. He's contributed a lot to the Southeastern Surgical Congress this past year. I know he's sat on many committees and been very involved with the success of this particular meeting. Dr. Sharma, come on up.
Thank you, Dr. Richards. I think that went on a little too long. We need to do some edits on that one. Wow. So thank you very much. And my first paper was here on familial hyperparathyroidism as a resident and a fellow, and still remains the largest series of 22. So somebody can beat that, I'm sure. So thank you very much for the opportunity to be here this morning and present on our work. And my only disclosure is that it is not my work by any means. I have an amazing group of collaborators, surgeons, anesthesiologists, nurses, analysts, surgery residents, and a lot of students. And yes, we are hiring, and that is we all need to be hiring nurses right now, so we are definitely hiring at Emory right now. So our goals are going to be quite a few, and I'm going to try to go through this as quickly as we can, which is talking a little bit about another quality of quality, which is agility, maybe a success story and a failure story, looking at how innovation can actually affect this, and looking at the value equation, and specifically focusing on what we have seen in the last year and a half over quality. We heard these themes mentioned at the American College of Surgeons afternoon session 2 days ago, and I think you'll see some similarities here. So some random facts to kind of set the context of today. 1 in 7 surgical patient is admitted readmitted within 30 days post-surgery. 1.4% of patient discharges had postoperative sepsis after discharge, after an elective procedure. From 2009 to 2011, we did not change our improvements in catheter-associated urinary tract infections. From 2008 to 2014, mortality based upon NSQIP data in colorectal surgery improved from 5.4 to 3.1% nationally. And in 2013, there were roughly 20% fewer surgical site infections. And last but not least is that low tidal volumes result in decreased postoperative pneumonia rates by 28%. So these are some of the outcome measures that we often talk about in the world of quality. I'm going to not focus too much on the outcome today, but actually the process of getting to some of these achievements and failures that we have along the way. This is not a new concept, even though this is a state-of-the-art lecture. What we're talking about today has been mentioned and discussed for century, I would say. Started with Codman, who focused on outcomes, but in 1998, for those of you who have not had a chance to read this IOM report, please do. In 2001, the Crossing the Quality Chasm came out of the same group. And they talked a little bit about redesigning the healthcare system, particularly measures of it. It was about care. It was about patient as a source of control. It was about knowledge sharing, decision-making based upon evidence, system property of safety being ingrained in every aspect of our care for our patient, transparency. Some of the needs were anticipated, and the outcomes that they were talking about were safety, effectiveness, efficiency, personalization, timeliness, and equity. And obviously they talked a lot about collaboration. And so this is now exactly 20 years ago. How far have we come? Post-IOM, lots of things came about, and these are things that these are systems that we're still working in. A significant amount of federal and state agencies developed their own data sets and their own benchmarks. The National Quality Forum, which continues to work today in vetting a lot of the quality measures, came about. The private sector, and we are seeing this come up with, I would say, a significant change in the last 10 years, have been private sector groups that measure quality, and Leapfrog and ProPublica are just some examples. And oftentimes what we deal with here, which are the professional groups, collaborative models like NSQIP, STS, VQI, SysQIP, the Hernia Society, and these are things that are all, where we do a significant amount of measurement. But again, as we look back in history, we see the same concept almost 70 years ago. And this was Dr. Avidis Danabedian, who was MD and then an MPH. His contribution was not about outcomes, but about giving structure to quality. And it was about, there's a parallel, structure would be the anatomy and the processes would be the physiology of delivering appropriate care. And obviously it was something that has existed for a long time, CMS until today, and it is a great op-ed written by Donald Berwick there. This is where we still are. His model is still what we are using in the world of quality. So what is quality? I would say there are probably about 3 major definitions out there. The Institute of Medicine is the desired health outcomes. IHI talks about outcomes management, unnecessary variation, and making things more predictable. And then last but not least is the consumer aspect of this, which is customer needs exceed the customer's expectations. And these are all approaches to quality. But what we're talking about today is agility. And it's a difficult thing to define at times, unless you have a look. In the business world, it's very easy. But in the quality world, I'll give you 2 scenarios. Scenario number 1 is you're walking into a meeting and your organization needs to adhere to new regulatory standards. Scenario number 2 is you're walking into a meeting, and this is actually a meeting from not too long ago, where the Commission on Cancer has templated op notes. And our goal is to incorporate those templated op notes for 5 cancer lines into our electronic medical record. In scenario number 1, you walk in, you find that the key perspectives are missing. There's no clarity. This is the same conversation that you had with another group a month ago or 3 months ago. Nothing has moved. The data that you're relying upon is quite anecdotal. Scenario number 2, however, is that, hey, you've had a legacy of doing this. So you know who's going to be accountable. You know the information dissemination is going to be rapid. So there's going to be someone who's responsible for that. We're going to be data-driven. And I think it's obvious that scenario number 2 is what we're talking about when we say agility in quality improvement. This is probably a good analysis for everyone to do in any team that they're part of kind of where we rank and where we function. If you look at the y-axis there, it's the dynamic aspect of a team. And if you look at the x-axis there, it's the stability aspect of the team. And you can see organizations, teams in all four of these realms. The trapped team, which talks about things like fighting fires, finger pointing, rigid. Words like stuck, tribal, turf, politics are used. A team that's sometimes often new, has a lot of energy, doesn't have a lot of stability yet, but they're functioning like a startup. It's a free-for-all, they're constantly shifting focus, but they're coming up with new ideas. Chaos is often a term used for a team like that. They're reinventing the wheel. They're probably not paying attention to what others have done in the past, and they're quite unpredictable what comes in. And where a lot of our healthcare, especially large healthcare systems, are kind of on that right side, which is bureaucracy, very risk averse. They are efficient at times when need be, but they're quite bureaucratic. Every decision is evaluated by someone else, and sometimes in many layers, but they are reliable. They're slow, they're siloed, they're established and centralized. And an agile team is probably a good combination of being dynamic and stable, where you're quick to mobilize, nimble, quick decision-making, resilient, you're collaborative. And obviously the last year and a half has pushed a lot of teams to work in this agile model. And we should learn from that. So I would say systemized agility and quality is dependent on four things: standards, structured implementation, some innovation, and it has to be responsive to failures. And at the end of the day, it is all about the patient, and it has to be patient-centered. This is also a major aspect, I would say, of agility. Before we get into some of the examples of success and failures, our curve for adopting new ideas or new innovation is the same discussions that we've been having for 50 years. There's a group of people who come in early. There's a group of people who come in the middle, and there's still people in laggards. And I purposely left that curve unended, because there's still people who have never adopted things that have come out as innovation and opportunity for better patient care. But agility is taking that x-axis and making that time interval shorter. How do we do that? These are the 6 pillars of quality, and it's kind of important to think a little bit about, besides just outcomes, efficacy, which is essentially, your hand washing compliance. Did you get 90%? Your efficiency, which is often talking about resource utilization, the minutes in the operating room. Did it cost you $1,000 to get your next surgical site infection prevented, or $100 to get your next surgical site infection prevented? Effectiveness, where did you actually improve the outcome that you were after? So if you did hand washing, did you actually reduce surgical site infection? Optimization, which is often where we fail, which is taking that idea, spreading across multiple service lines, and making sure it is value driven. The cost is very important to evaluate in this. And last but not least are acceptability and equity, and where disparities, patient expectations come into play. These are all pillars of quality, and they all have their own roles and their own measuring techniques. So when we talk about standards and implementation, we often talk about, and everybody understands this here, reliability. We talk about measurability. We talk about the ability to evaluate it. We were just in the session before where people were looking at standards critically and appropriately. Complex decision-making can be reevaluated. The value equation and variation analysis and what we call the lean learning loop can be applied. And those are the benefits of standardization. Obviously, with it also comes some rigidity too. This is an example from my own service line, and without knowing all the details here, this was a survey of 700 plus physicians who from 1,159 COC programs. And just to ask what they would do with a 0.8 centimeter, again, less than 1 centimeter, thyroid cancer. And you can see how we were split. 52% recommended a total thyroidectomy, 22% would do a central lymph node along with that, and 25% would do a thyroid lobectomy. So we're not really following the standards, or at least not practicing with the standards that have often been established. In the same data set, when you looked at radioactive iodine, it was split down the middle, 50-50. So we have a lot of opportunity. And I pick on my own service line, but we can pick on anything in this. We are not following these standards. So an attempt, a very impressive attempt was made by Dr. Barry Nabnett, who will be giving a lecture later today. And I was part of this team where we developed a collaborative that would specifically look at outcomes, but also look at workflows, look to see if we're adhering to standards. And SysQuip has, it's been around for now about 5 years. We are a CMS approved entity, and quality measures are submitted to CMS for reimbursement purposes and for some of the MIPS measures that are out there too. But there's some things that are very standard that are not often done, like preoperative ultrasound exam of all patients with thyroid cancer. It was impressive to see how we're failing at that. I think there's lots of opportunity for us. So one shameless plug for endocrine surgery there. But then another example of a very successful standards program was the MBSA QIP. And this was motivated obviously by some insurance issues and reimbursement issues, but the standards that were set here across patient equity, experience, in a 4-year period, mortality reduction, readmission reduction, bleeding reduction, UTI reduction, SSI reduction, and med reconciliation improved. And this is an example of a verified and a verification program. And the college has quite a few that I think can serve very good as standard building exercises or standard delivery or standard implementation exercises. These are some examples. Strong for surgery, where we look at preoperative factors. ISCR, where we look at intraoperative and perioperative and postoperative processes and they're across gynecology, orthopedics, and colorectal surgery for right now. This is an example of probably a phase of care where we have the most opportunity for standardization and expectation setting, which is a pre-op phase. Obviously, our goals as surgeons is please don't cancel my case, but it is also about reducing variability in testing and improving patient readiness for surgery. This is an example of something that was presented almost 7 years ago in almost 6,000 patients when there was a nurse-driven and computerized-driven protocol. The pre-intervention mortality, which was of 3.5%, went down to 1.9%. There were only 200 cancellations and only 147 cardiology referrals made. So having standardization in the pre-op process is something that has been of significant value. As we move along, we ask the question, why do we not see a greater application of standards in frontline care? Most often, it's us, our infrastructure, and the ability to adopt technology into our daily flow. We have not paid significant attention to that at all. We have amazing electronic medical record systems that have not been leveraged to help us in workflow management and to give us pointers when we're veering off those workflow standards. So this is often what happens. Evidence-based guidelines have a proper implementation. A predicted outcome happens, an unexpected outcome happens, or unnecessary resource utilization happens. Deviation can often happen too. The last three are not accounted for. If we look at Dr. Nakayama and his work with the American surgeon, when we look at papers, we rarely find the last three accounted for, and that is one of our probably our opportunities. It is often the imperfect, the stakeholders aren't involved, and it's often a clinical workflow issue, but these are things that are not accounted for often in literature. I think innovation can change this. So in 2011, and I'm not going to go through all of this, but we had a major event. We had a major NSQIP report that freaked us out, I would say. We were in the 10th decile, not used to being in the 10th decile at Emory, over surgical site infections. And I'm not going to go through all of this in detail, but we formed a group. All the stakeholders were there and they're represented here. And then as we went along, our wound infection prevention process was developed. It was all, I think, what everybody would do here. We had pre-op phase, peri-op phase, intra-op phase, post-op phase. We used significant amount of patient education. iPad app was developed that spoke about smoking cessation, what to watch out for surgical site infection, hyperglycemia control, MRSA issues. Patients were instructed to do a preoperative shower. A checklist was developed. Most of this has been presented, so I'm going to move through it quickly for time's sake. And yes, 2 years later, we had an improvement. We went from an 18% infection rate down to 8%. Were we able to sustain this? It looked like over the next 5 years, we were able to sustain this across colorectal. And as things, you do something well, you expand it. We expanded across other service lines. When we looked at our best practices, These are the best practices for surgical site infection. We found two areas that we were not successful in, normoglycemia and normothermia. And I promise you, we've been working on that for 6-7 years. The things in red, we never attempted. Everything else, we felt like we were doing a good job with, or when we had compliance measurement, we were greater than 90% compliance in. So how do we work on normoglycemia? Glycemic evaluation is part of our pre-op, and about 28% of our patients are at risk for stress glycemia or prediabetes or diabetes. So it's a significant amount of our patient volume. This was something that we had significant issues with hypoglycemia when we were overtreating and significant issues with hyperglycemia when we were undertreating. An app was developed, Dr. Vikas O'Reilly Shah, who did this. The app is available. It's not public yet, but it basically went through, it's called SugarX. This is an opportunity for innovation, definitely. And the app is pretty self-explanatory. You select the diabetes the patient has, the risk factors they have, and it comes with a protocol. It's available as the anesthesiologist is managing the patient intraoperatively. And the outcomes of the app was we had reduction in hyperglycemia by almost 80% and reduction in hypoglycemic events by 345%. And we had been attempting improvement in this area for, I would say, 6-7 years, at least since I was involved. These stories are not uncommon. We have sustainability issues in almost every quality improvement project. And when we get to this phase where we've expanded our wonderful surgical site infection rate, we've pushed our wound infection process across multiple service lines, we find an area where we're very happy, a time period we're very happy, and a time period we're very sad because we're failing. And in that time period, it's roughly 443 patients. So it's a significant number of patients that had surgical site infections. And we look at what we were missing, and we were missing our skin prep opportunity. It was a very small group of patients, but there was a huge difference when we were compliant or not compliant. And we were missing antibiotic prophylaxis. Things that are very simple, things that we've been talking about for decades. We had some issues with temperature, as you can see there, but not significant. Our focus was going to be antibiotics. And again, we used some informatics and some SQL programming to fix this. We identified 20 barriers to delivering antibiotics appropriately. And the new process that was created was protocolized antibiotics based upon CPT code. No order would be necessary. The antibiotics would be housed in the operating room. And we eliminated about 13 out of 20 of those barriers. In that process, we improved at 3 hospitals. We improved antibiotic compliance from 88 to 95%, 91 to 96%, and 64 to 98%. And if you had looked at what the antibiotics were doing, what we were doing with antibiotics, we were checking off a box saying that we gave antibiotics appropriately, which is what was expected in SCIP. It was not enough. And so we had to redo the programming, to look at timing, redosing, and appropriateness. And when we found the truth, quote unquote, it was very different than oftentimes the intent checkbox that we had used in the past. Over 8 years of doing this, about 13,000 patients in one single hospital, 443 SSIs prevented, 130 pneumonias, 206 UTIs, 281 readmissions, and 150 mortality events. And the mortality reduction is priceless. I'm not going to try to put a price tag on that, but if you did put a price tag on the rest of the events, that's $15.6 million saved for our system. And that is roughly $2 million per year with participation of a platform that's less than $200,000 a year. So obviously this year, last 5 minutes I want to spend on is this last year or a year and a half. Something like this happened to all of us, where our systems were tested from a quality standpoint, from agility standpoint, and we weren't really sure if we were going to make it through. And we're having again that issue this past month also. This was our positivity rate, and from a local data standpoint, anywhere from 20 to 40% on a weekly basis. We are in this last surge right now where we're running about 20% for symptomatic patients, about 4 to 5% for peri-op patients, which is, again, not where we were 3 months ago. The same group of people that helped with the IOM report got together and basically gave us recommendations. These are on the wonderful COVID website maintained by the American College of Surgeons, but it specifically talked about reducing harm, improvement opportunities, and capturing data, making sure that the patients are involved in these decision makings, particularly around adjudication and cancellation, and then assessing the readiness. This is the resource center. Please go to it. It is very well done. And I would say thank you, Dr. Sharp, for doing an amazing job. This was something that we relied upon heavily for developing our protocols. This is, I think, the mantra. As you can see, Zoom meetings and other things happened. This used to be a full venue. But yes, you really don't know how strong you are until you're tested. And we developed 6 major platforms: team structure, alignment, standard guide development, operational and data support, communication, surge planning, and readiness. And without going through all the details, what I'd like to say is that the data that was available in the beginning of the pandemic was extremely poor quality. It continues to be not the strongest quality, but there's some still opportunities for all of us to participate in that data. And when we look at the ACS registry, and I'm just going to move along because I know I only have 3 minutes here, but when we look at the ACS registry, please participate in this. We were lucky that we had a pre-COVID simulation program. When it came to the new COVID guidelines, the perioperative process, we were able to put all our team members through this, through a walkthrough, through a simulation. And as Dr. Richmond and I were talking about yesterday, the first tracheostomy was very nerve-wracking in a COVID patient. Having simulation, having the ability for a perioperative process to be talked about, spoken, defined in this initial planning phase was a tremendous value, not just from a patient outcome standpoint, but from a team psychology standpoint. This was our first version 1.0, and this is not version 1.0 anymore, but this was how it was done in February. We went through everything, how a patient is going to be transported, what the doffing and donning is going to be for PPE. And obviously we were on version 15.0 by now, but it was amazing, the group of people that came together to get the patient through COVID positive procedure. This is published in the in Annals of Surgery, and it's please take a look at it. It is very interesting, the details that are often present and needed to get a patient properly through a COVID positive procedure. Again, plug for the registry, please participate, and I will show you some quick data from the registry in the last 2 minutes. The data is going to be about COVID versus COVID positive versus COVID negative, symptomatic versus asymptomatic, and the timing of the test. Not going to go through all the service lines, and I apologize for this, but you can see the NISQA benchmarks for our hospital are to your right. The patients who went after a procedure to the ICU versus non-ICU, you can see their outcomes. Pneumonia rates of 50 and 60%. Sepsis rates of 60%. In the non-ICU patients, sepsis rates of 18%. These are nowhere near the benchmarks that we have traditionally had for our patients. And so there's a significant accounting that needs to be done for why this is happening. Are we appropriately delaying elective surgery? Are we having to move on all surgery? And the answer is, when we go into the 14 and 30-day period and the 30-plus day period from a positivity, the outcomes come back to the benchmark. Dialysis outcomes, emergent surgery outcomes, COVID-related complications, and in particular mortality. We get down to what our NISQA benchmarks are. So we are currently practicing 30-plus day from positivity unless it's an emergency or urgent case. So I think there are some other things that we have not accounted for. Those have been discussed at this meeting. The delays, our significant amount of patients have had chemo delays. Our screening for colorectal cancer has been impacted. Even thyroid cancer, which is fairly indolent, there are some delays that are being noticed in the SEER data. We are operating on more complicated patients for sure with diverticulitis, and we've talked about trauma volume. These are things that are going to change the realm of quality, I would say, in the next year for sure. Our current needs are accounting for resources, staffing, utilization, and burnout. We have not done that in our patient care models as of today, although the conversation has started. So thank you very much for the opportunity to present here. I think the Brent James quote here, if culture eats strategy for breakfast and infrastructure eats culture for lunch is true. Our job as quality gurus is to clear the path for the next person coming down the pike. And this is the team that has been absolutely part and parcel of my life for the last 10 years. And they're an amazing group of people, and none of this would be possible without them. So thank you for the opportunity, Dr. Richards, to present here.
Dr. Sharma, that was absolutely amazing lecture. Congratulations on really creating a fantastic program. I'd like to, on behalf of the Southeastern Surgical Congress, give you this plaque.
Thank you, sir.
Congratulations.
Thank you, Dr. Richards.
Thank you.